Good afternoon, everyone. I'd like to call the Health and Human Service Finance Division to order. Welcome, everybody. I'm delighted to see such a full room. We apologize for the heat. We realize it is rather warm in here, and we're taking steps to get the heat turned down. I hope the heat isn't a metaphor for something, but I'm glad to see you all here. We are going to get going, and I just want to, before we start with Attorney General Ellison, I just wanted to give everyone a little bit of a roadmap here. So there have been some community conversations around the state to talk about and to hear from, most importantly, to hear from people who are affected by the high skyrocketing price of insulin. And so we're here today. We're going to hear, first of all, an update from Attorney General Ellison on the Advisory Task Force on lowering prescription drug prices. And we're taking the Attorney General first because he has to be somewhere else. So we're starting with him. But then we're going to go into an update on these community conversations and talk some more about the Alec Smith Emergency Insulin Act. So Representative Howard is going to give us an update on that. We're going to hear from some advocates, and then we're going to have some discussion. Following that, we're going to hear from some of the health plans about what they've been doing around this same issue and have an opportunity there to have some discussion with them as well, I hope. So we're going to get moving and appreciate everyone being here. It's great to see everyone. It's been probably, I know some of us have seen each other at different things, but it's good to be back together and to deal with this very important issue. So welcome, Attorney General Ellison, and please go ahead.
Well, Madam Chair, thank you so much, and let me thank all of the members for being here today. From the fullness of this room, it's very clear that your topic today is of pressing and urgent public concern, and I will assure you that the experience of our task force on lowering drug prices reflects the urgency and the interests of this committee hearing. Our group is bipartisan, 2 Democrats, 2 Republicans, 2 House members, 2 senators. We cannot afford to allow this critical issue to lapse into some sort of political football because people's lives are literally on the line. We are urban, we are suburban, we are greater Minnesota. We have a great diversity in terms of background and experience. Some of our members are people who use medications like that they depend upon to save their lives. Others are people who work in the industry. We have people from government, private sector, and we always have an ample number of people who use the time that we allot for public comment. We are, I'd say, about halfway through our work, and we expect to have a report issued in January. The findings we plan on having start with work that the Attorney General's office is going to do, because we don't believe in having task force just to figure out what to suggest other people do. We're taking responsibility on our own shoulders first, but we will have some legislative proposals, and we will have some administrative proposals and other community proposals that might not involve government at all. But we look at this as a multi-pronged problem. But Madam Chair, insulin is without a doubt a recurring theme of our task force because of the tremendous urgency. A number of people, due to rationing, due to the high cost, have lost their lives. So this does occupy much of our attention and thought. As a people's lawyer, which I consider myself to be, I've heard from people in every corner of Minnesota that we are just having trouble affording our lives. And the cost of prescription drugs is a major factor in that. They're all united in one simple idea. They're entitled to afford their lives, and drug prices are just too high. To address this problem, I formed a task force for lowering the cost of pharmaceutical drugs. I have charged the task force with gathering in the best thinking in order to understand why the prices of prescription drugs are so high and in some cases unconscionably high, and come up with multi-pronged strategies to lower prices. These will include legislative, legal, regulatory, and community-based strategies. I already told you a little bit about the makeup of our task force. I hope you'll indulge me just to mention the names of some of our participants. Our co-chairs are Nicole Smith-Holt, who lost her son due to having to ration prescription drug insulin. But also our co-chair is Senator Scott Jensen, who's a physician, but also Senate District 47. Sherlyn LaChapelle is a nurse consultant. She's also the president of the Black Nurses Association. Dr. Leonard Snellman, general pediatrician, HealthPartners. Christy Kewen, she's a patient advocate. Rose Roach, executive director of the Minnesota Nurses Association. Dr. Stephen Schondelmeyer, he's the director and professor of Prime Institute, University of Minnesota, foremost expert on prescription drug prices in pharmacy. Elo Alston, who's a patient advocate. He comes to our meetings in a wheelchair, and coming up with the proper outcome is directly and personally important to him. Nazia Iftikhari, founder and CEO of Health Ease. Fu Hewen, pharmacy manager at North Point Medical Clinic. Jessica Braun, nurse practitioner. Dr. Cody Weiberg, executive director of the Minnesota Board of Pharmacy, who's here today. And Senator Matt Little, Senate District 58. Representative John Lesh, House District 66B. And Representative Rod Hamilton, House District 22B. We have had four full task force meetings thus far, including one just yesterday, and we have 4 scheduled meetings remaining. Public testimony has been taken at each task force meeting. Our work will be completed and a report will be issued by January. We've also had listening sessions in addition to task force meetings. One of them was in Worthington, another in Chaska, and dozens of Minnesotans have attended these listening sessions and provided critical input. The task force is also broken down into smaller working groups, and those working groups have met outside the full task force meetings. The area of the working groups and the focus and topics have been Legislative Regulatory Action Group, and their task is to determine the role of federal and state legislative and regulatory actions in lowering drug prices. The second working group is Causes and Contributors. Their task is to identify the root causes and contributing factors to the increase in pharmaceutical drug prices. Number 3, past, current, and future strategies, to conduct a comprehensive analysis of various strategies that have been and could be undertaken to lower drug prices. And so those are our subgroups. In the course of our work, Madam Chair, we've had the opportunity to listen to a lot of people. Allow me to just share with you very quickly that in Chaska, a young woman named Chelsea talked about her 8-year-old son was diagnosed with type 1 diabetes at 18 months. She got involved with the local organization for juvenile diabetes research and went to D.C. as a parent advocate, attended a luncheon sponsored by the drug company, and later found out that there was a lawsuit against them for using patients to make generic drugs unavailable. Michelle shared that her son is a type 1 diabetic, and when he was diagnosed in 2009, a vial cost $35. The same vial today costs $233, and her son goes through one vial every 10 days, so they're paying $700 a month. She was diagnosed with breast cancer and paid $900 to $1,800 per treatment in her cocktail. One drug cost $2,500 for a 30-day supply. One cancer drug affected her pancreas, and she now has diabetes. We're looking at a number of recommendations. We don't have them yet. That's what we're actually doing, is developing the recommendations. But I think I can tell you preliminarily, a number of things we're considering are focusing on recommendations such as these. Minnesota should know what it spends on prescription drug prices. The committee has talked a lot about transparency making sure that the story gets out, that people know what they're buying. And I would say that sometimes in this body and all over the country, we debate free market versus government intervention. But I've never met any free market advocate who thinks it's okay to have opaque markets. One fundamental basis of any market structure working properly is information, and that is something that I think we all can agree on. Number two, Minnesota should act as a prudent purchaser of prescription drugs. That is a recommendation that has been made and the committee has discussed. Minnesota should facilitate new, more affordable channels for prescription drug purchasing. Examples involving an insulin, EpiPen, naloxone. And Minnesota should encourage and facilitate drug price transparency. Minnesota should prohibit perverse economic behaviors related to prescription drugs, such as identifying market behaviors that lead to perverse economic consequences that may mislead Minnesota consumers. I can assure you that this is something that the Attorney General's office is looking at, independent from our working group. And let me just wrap up, because I know a lot of people are waiting to talk. Minnesota should identify and address price gouging related to prescription drugs. Minnesota should establish a process for assuring affordability and accountability of prescription drugs. Minnesota should provide oversight of PBMs and their market behavior. Minnesota should assure patient access to pharmacist services for effective medication use. Minnesota should support research on prescription drug prices and drug benefits. Let me just wrap up by telling you this. My office is not simply relying on the task force as much as we are proud of it and working carefully with it. In addition to the task force, my office is pursuing legal action right now on pharmaceutical drug prices. As to insulin specifically, Minnesota is currently suing 3 main manufacturers, including Eli Lilly, Sanfoy, and Novo Nordisk, alleging that their list price published was deceptive. The case remains pending, but just this morning, we filed a response to the defendant's motion to dismiss, which we are vigorously opposing. Of course, that is what our mission is. Minnesota is the first state in the country to advance this case, and Kentucky has followed us, and New York is currently investigating. There is a lot of benefit in the multi-state lawsuits we do, and we're hoping to build. So finally, and this is my last comment, Madam Chair, the committee members, again, thank you for having me here today. The work of this task force looks at the costs of all prescription drugs, especially those that Minnesotans rely on to stay alive. Insulin is one of those drugs. Our report will be issued in January, will include recommendations for insulin, but also many other ways to lower drug prices. That said, Minnesotans with diabetes need help now. They're dying now, and it would be prudent for all of us to focus our attention on how we can deliver relief now. So with that, let me again offer my sincere thanks for your attention to this critical issue. It's something we all should, join hands together and figure out how to solve. And I will say that one person who's not on our committee, but it has been at every committee meeting, I just want to recognize Representative Pearman, who has never missed a meeting, and you wouldn't know he's not actually on the task force, but there are certain numerical limits on membership. He doesn't care. He shows up anyway. So I want to say thank you, Representative. That's all I have today.
Well, Attorney General Ellison, thank you very much for that presentation. And I just want to give my appreciation, and I'm sure all of our appreciation, to all the members of the task force, including the ex officio member, I guess, Representative Bierman, for doing that hard work, and really looking forward to seeing what you come up with for us. Because this is a problem that is, I think pretty much every state is wrestling with this problem. This is not just a Minnesota problem. But here in Minnesota, we have a lot of creativity, a lot of good minds, and a lot of ability to form partnerships and find solutions. So thank you very much for helping lead that effort.
Thank you, Madam Chair. And I'll just add, Madam Chair, that our country hasn't really taken antitrust litigation seriously in the last 40 years. It's a bipartisan failure, in my opinion. But, there was a time in this country where we used the Sherman Act the Clayton Act, to bust up trusts and make sure we had competitive markets and innovation.
That's right.
And my office is returning to really take antitrust enforcement seriously, which I believe will lead to more diversity in product and lower prices. So with that, if there's nothing else, I'm
Thank
here
you
to
very
stand
much.
for questions, but other than that, I'm,
Thank you very much.
thank you,
We
ma'am.
really appreciate it.
and thank you, members,
Thank
as
you.
well.
All right, we are going to move on then to the update on the community conversations and talk about the, what's going on with the Alec Smith Emergency Insulin Act, and Representative Howard.
Thank you, Madam Chair and members of the committee. I am happy to be here today to talk about the Alec Smith Emergency Insulin Act and update folks on a bill that has been more than a year in the making. And as part of that, I want to talk a little bit about where we've been and how we've gotten here to this point, and to express some optimism that we have an opportunity to move forward and get this done. I mean, this shouldn't be a left or right issue or a red or blue issue. It's a life or death issue. And it's of utmost importance that we work quickly to pass the Alec Smith Emergency Insulin Act and make sure that never again in Minnesota does someone lose their life because they cannot afford the insulin they need to survive. So how we got here, as I mentioned, this bill has been more than a year in the making, and it's really a bill that began being formed at the kitchen table of Nicole Smith-Holt and James Holt, in listening to the story of their son Alec, who passed away rationing his insulin at 26, and wrestling with this question: how do we stop this? How can we make sure that this never happens again? It hits everyone in our gut that this is just wrong and should never take place in Minnesota. And so we got to work. We worked with Minnesotans with diabetes, stakeholders, to try to build a program that would create that safety net for Minnesotans, so that if someone was in that impossible choice of needing their insulin, which they absolutely need to survive, and not having the money to afford it, there would be a safety net to make sure that you could avoid death. And so we worked to develop a strong bill that we passed in the Minnesota House. And as we all know, that bill was blocked by the Senate at the end of the legislative session, and we weren't able to move forward. But we kept working. We heard from Minnesotans across the state who were frankly outraged that this legislature wasn't able to get across the finish line. And that public pressure from Minnesotans, especially those with diabetes, I just have to offer my utmost gratitude and thanks, because there's no question we would not be in this position if not for those Minnesotans continually to share their brave story and to push us towards action. So we kept working. There was a bipartisan working group formed that Senator Matt Little invited a group of bipartisan, bicameral legislators to keep working on this issue. And I want to thank members of the House, Representative Mann, Representative Morrison, and Representative Hamilton for participating in that group. I also want to thank the Senate author, Senator Wickland, and Senator Jensen and Abler for offering their contributions to that group as well. And we did good work. We discussed the issue, the bill, and have, with some bipartisan recommendations, made a strong bill even stronger. And I'm going to talk about that in a little bit. What we also did to strengthen the bill is hear from Minnesotans across the state. We've had multiple listening sessions across the state to hear from Minnesotans impacted by diabetes. And we heard just emotional, strong, courageous testimony from all corners of the state. And, you know, frequent stories from attendees about rationing their insulin and trying to determine the least amount that they could take to prevent going to the hospital. We heard concerns about supplies, challenges working with providers to ensure that their medication is covered. We heard from healthcare workers who have seen an increase in Minnesotans coming through the emergency room because of problems associated with affording their insulin. We heard of concerns and fears from parents of children of what's going to happen when they age off their insurance, and just many of the day-to-day challenges. And I'll say what I was left with from those hearing from those Minnesotans is that this is a statewide problem that affects us in every corner of the state, in every community, young and old. And the scope of the challenges are immense. And this bill, emergency insulin bill, is going to hopefully tackle job number one, make sure that no one is losing their life. But this is an issue that we need to wrestle with going forward. And the other takeaway that I was left with more so than anything was the feeling of fear that so many families and Minnesotans face. You know, they might have a handle and a coverage now to cover their insulin, but what if they don't? What if my daughter, who's 18, as we heard in Richfield, what happens when she ages off our insurance? What happens if I lose a job and my coverage goes away? And that strikes at the heart of why this bill is so necessary. We absolutely need a safety net so that Minnesotans have that security, that guarantee that with a drug that is life necessary, there's a system in place to make sure that they will have access to it on an emergency basis. With that, I want to walk through the bill, and in particular, focus on areas that have been improved upon since I was before this committee talking about the Alec Smith bill during session. And it is very similar, but I would say it's strengthened in a variety of ways. But its structure and purpose are very similar. We're providing a safety net for Minnesotans most in danger of being in an emergency situation and not being able to afford their insulin. And we are putting a structure in place that would be paid for by the insulin manufacturers that have profited richly while the prices went up and up and up. The changes that I want to mention, first of all, we have reduced the barriers for patients to access their insulin. And I want to thank members of the bipartisan working group, in particular Senator Jensen Abler, working on this issue. We've developed in our program, if a Minnesotan is in need of insulin, they can bring a form to attest to their need into the pharmacy and get an emergency supply, 30-day supply of insulin that day in the pharmacy. And we think that's incredibly important because, as we've heard from Minnesotans, this is a dangerous, not having a supply of insulin is a dangerous issue that can onset very quickly. We can't afford to have a system where there are multiple weeks lag time before people can have access. That wouldn't truly be an emergency access program. So we've reduced those barriers, and this is vitally important. We've also increased the eligibility to include more people. That's from conversations we've heard from Minnesotans. And again, it was actually a suggestion from Senator Jensen. So we have increased eligibility from 400% of federal poverty guidelines to 600%. For an individual, they would be earning about $70,000 a year. We have also included language that strives to connect Minnesotans to better long-term resources to help them manage the cost of their insulin. Because we know that job number one is to address the emergency that Minnesotans might find themselves in. But we also want to make sure that we are connecting resources, or connecting Minnesotans to resources that are available, whether it be insurance coverage or other programs that might serve them well. And lastly, we know that accountability is important. We've added a report back to the legislature to better understand how this program is being utilized and to learn from it. You know, in a perfect world, this bill isn't necessary. I hope that after we pass this bill, it can go away because we've solved this problem. But we want to report back to the legislature to learn of how it's being utilized and improve upon it if necessary. And as I mentioned, remaining in this bill is a payment structure that asks the insulin manufacturers to pay a fee to cover the cost of this program. And we think that's very important. A vial of insulin that cost about $30 in the 1990s now costs over $300. And we know that 3 insulin manufacturers controlled the entire global market and have raked in profits in the billions and billions of dollars while the prices soared. We believe a modest fee that would be a sliver of the profits of those companies to ensure that they're having a stake in solving this problem is more than fair. And I did want to comment briefly on the Senate proposal that was offered this week, and it provides optimism. It gives me optimism that we can move forward here. You know, the Senate has worthy concepts. In particular, they Their plan is concerned about trying to develop some long-term solutions for folks on insulin. But to be clear, it isn't an emergency program, and that's job number one. But their goal of connecting folks to long-term care options is worthy. So I'm optimistic that we can address the emergency crisis in our bill, in the Alex bill, and in addition, work together to tackle those long-term challenges. And lastly, I want to express optimism that the Senate has now agreed with the House that insulin manufacturers should pay for this program. Their plan is funded almost entirely by asking insulin manufacturers to pay. That was clearly a big stumbling block at the end of the legislative session, and that we've reached consensus on that item, I believe helps us take an important step to get this done. Lastly, before we hear from testifiers, my only comment is that we should still feel that same pressure we felt on that last day of legislative session when this didn't get done, because it's not theoretical. It's a life and death issue. Since our session adjourned, we've lost another Minnesotan from rationing their insulin. And we need to ask ourselves, are we comfortable with any more Minnesotans having that same fate? And the answer should be a resounding no. We need to work together to pass Alec's bill so that no one ever again loses their life because they can't afford the insulin they need to survive. Thank you, Madam Chair.
Thank you, Representative Howard. I appreciate that, and I appreciate your assistance in organizing those community conversations, and a lot of us were at those. And I have to tell you, I left everyone just, they were so heartbreaking, the stories that we heard. And I think you're so right that the emergency aspect of this is so important. The idea for people that there is a safety net, even for people who might never need it, that it's there. Because one of the things I heard in some of these meetings is that even the effect of anxiety on people who use insulin, who are type 1, and how this can affect their blood sugar, and really the pain and agony of the insecurity that we heard was just, this is going on, as you said, everywhere in our state. The other thing that was kind of brought home to me is that this could be any of us, because many of the people we heard from, some of them became diabetic in childhood, others later in life. I think we even heard from one woman who must have been perhaps in her 50s when she suddenly became type 1, kind of without warning, if I'm remembering this right. So if anyone thinks they're immune to this, think again. Neither we nor our families are immune. This is something that can affect any one of us at any time, and as a state, it really behooves us to have, at the very least, a safety net. So, as you say, nobody should die from lack of insulin. This just should be a never event, right? Like we talk about, hospitals should never cut off the wrong leg. No one should ever die from lack of access to insulin. So thank you very much. I'm going to call up now Nicole Smith-Holt and Cindy Scherer Boyd. If you would want to both come up together, that would be terrific. And welcome to the committee. And if you would just please introduce yourselves and go ahead and tell us what you'd like us to know.
Thank you, Madam Chair and committee members. My name is Nicole Smith-Holt, and I am the mother of Alec Smith. Most of you have heard the story of how in 2017, Alec died from rationing his life-sustaining insulin because he could not afford to pay the $1,300 bill at the pharmacy. Because you've heard about his death already, I won't retell my story. But we're here today to talk about the implementation of the Alec Smith emergency insulin bill. I believe this bill should be created and passed immediately. This is a true need for those in Minnesota who are type 1. Minnesota needs this bill. This bill is a safety net for all of those who require insulin to stay alive. We should also make sure that the insulin manufacturers have the responsibility of providing funding for this bill. Eli Lilly, Novo Nordisk, and Sanofi have single-handedly raised the price of insulin over the past 20 years by 1,200%, making this product that nearly 500,000 Minnesota residents rely on unaffordable. We all realize that many people are one paycheck away from homelessness, one crisis away from bankruptcy. But for a type 1, a change in job status, turning 26, a divorce, or even an unexpected car repair could mean life or death. Far too often, I'm reading messages or posts from people who are just plain fed up. They're exhausted and tired of the financial burden of this diagnosis. People are actively giving up on their life. They're planning their own funerals. They're just done. It breaks my heart to hear this because diabetes has come so far over the years. The outlook is so much better than it was 50 years ago, but unfortunately, the financial aspect of this disease is taking people back 100 years to when this disease was a death sentence. I spend on average 10 hours a week coordinating insulin and supply donations and getting them to people in need. Since when is it acceptable to rely on the generosity of others to stay alive? I personally could not imagine depending upon a broken system or the kindness of others for the gift of life. The rate of diabetic ketoacidosis hospitalizations for adults in the US are double what they are in Canada. Can you guess why? Cost is one reason. Canada pays 1/10 for the same product that we use in the US. The other reason would most likely be because in Canada, insulin is sold over the counter without a prescription, so this improves accessibility. Many people who use insulin in the US struggle with their insurance companies to even get access to the insulin. We acknowledge that this bill does not bring down the price of insulin, that it is in the works, but for now, for the immediate crisis that people find themselves in, we need to pass this emergency bill. We need to hold manufacturers accountable, and we need to save lives. This bill would have saved Alec, and it would have saved Jesse. And if we can save just one more life from all of this hard work and dedication from this amazing team, I think we would be successful. Thank you.
Thank you very much. Welcome.
Hi. My name is Cindy Boyd. My son is Jessamiah Scherer Radcliffe. He passed away 90 days ago due to insulin rationing. The Alec Smith Emergency Insulin Act was not passed on May 28, 2019. At that time, those who defended their inaction made inaccurate and misleading statements about type 1 diabetes, insulin use, and availability. It seemed that they did not grasp the emergency. 30 days later, on June 28th, I found my 21-year-old son, Jessamiah, a person living with type 1 diabetes, dead from diabetic ketoacidosis. On April 4th, he was hospitalized with diabetic ketoacidosis. In the hospital, Jesse admitted that because of some financial difficulties, he had been rationing his insulin. He had insurance, he worked full-time, but with the prohibitive cost of insulin, he could not afford what he needed to live. So I asked myself how, just 2 months later, did we find Jesse in his home having died from diabetic ketoacidosis? How could this be? We had just seen him 2 days before this, and he seemed so healthy. I will tell you how. Diabetic ketoacidosis can develop in less than 24 hours. The detectives who came to his house determined that he did not have the insulin he needed to keep him alive. Jesse died the day before he was paid. He was trying to ration his insulin to make it to the next payday. Every day I deal with the pain of finding my son dead because he did not have the insulin he needed to keep him alive. It angers me to know that pharmaceutical companies are charging historically high prices for insulin with no explanation, and that our children are dying or playing Russian roulette with their lives because of the greed. We need the Alec Smith Emergency Insulin Act to pass so that we may save others' lives who are facing the same issues that Jesse faced. We need the bill passed so that people can get prescriptions filled on an emergency basis, and we need drug makers to pay for it. Studies indicate that 1 in 4 diabetics have resorted to rationing their insulin due to lack of access to affordable insulin. Are we really going to risk losing another diabetic because we can't make a decision and get this bill passed? The emergency access in this bill is clear, but the emergency is passing this bill now. Time is precious, and I wish that I had more time with Jesse. Don't take time away from another mother, father, brother, or sister of another person who is insulin dependent. Please pass the Alec Smith Emergency Insulin Act.
Thank you very much. Thank you for being here today. And I know, please, just to let the audience know, we can't respond and clap and stuff like that in the hearing, but we really appreciate your being here and your activism around this issue as well, because, you know, we do know that this affects so many people. And actually, that 1 in 4 statistic is really pretty shocking. 1 in 4 diabetics, type 1 diabetics are, I assume, are actually rationing their insulin.
It's probably more. That's just the number that's reporting the actual rationing. There's a lot of shame behind not being able to afford, you know, basic supplies like your insulin.
Yes. And Ms. Smith-Holt, I wonder if you are able to talk a little bit about the difference between the Alec Smith Emergency Insulin Act and the bill that was introduced in the Senate. I assume that you've tracked that. And could you just, you know, make it really clear to people kind of what, we're not saying that that is a bill that's a different version of this,
No.
right? Could you
No,
explain?
you know, from my standpoint, these are two bills that would go hand in hand with each other. You know, Alec's bill is going to touch on that emergency situation, whereas the Pratt bill, the Senate bill, is more of a more of an urgent. You know, that's how they described it at the Senate hearing, and I completely agree with that. It is more of once we get out of this emergency situation, this is the secondary bill that would help. So I believe that they would go hand in hand.
Okay, all right, thank you. So I think at this point, we could probably take some questions from members or entertain discussion if members are interested in that. I think Representative Cantrell, were you wanting to make a statement?
Not at this time, Madam
Okay,
Chair,
okay.
but I probably will be.
Okay, all right. Representative Munson.
Thank you, Madam Chair. And Representative Howard, when we had a lot of discussions about this bill last year, because you sit next to me on the floor, I'm curious about some of the changes that you proposed to make to the bill, really about expanding the coverage for people to go down to 600% of the poverty level, in which for a family of 4 is over $150,000 a year. Do you have a new fiscal note on this bill?
Representative Howard.
Madam Chair, Representative Munson, we're working to get one. I think we'll have one soon. There has been not only that change, but there's been changes in the insurance market. We have a few insurers that have frankly stepped up to have a stake in reducing copays, and that might have an impact on the fiscal note as well. Just an aside there, you know, we've seen some of these insurers step up. What we haven't seen is the insulin manufacturer step up. And so that's still a critical piece of this. But just based on my conversations, and I would estimate that the fiscal note might not look altogether different than the bill we had before us in session. But what we should know soon.
Okay.
All right, Representative Munson.
Madam Chair, thank you. And Representative Howard, thanks for the answer. I can't imagine moving it, the level of availability up to $150,000 for a family of 4 wouldn't encompass an enormous amount of Minnesotans. And this bill also talks about, you've changed the language in this engrossed version to include people that have insurance, but where their deductible is over $5,000, which is a large percentage of the private market. So they have insurance, and you know many of us have large deductibles too that we have to meet. That I have concerns. The one thing I wanted to ask you about is how the fee is calculated for the insurance company or for the pharmaceutical insulin manufacturers. Because we discussed before how I think this is really going to be just a fee that is put back on the consumers of insulin for the people who don't go through the program, that they will then have to pay a now much higher cost of insulin. And the way that the fee is calculated in this bill is, let's say that you have 3 drugs that are being offered, just for an example, from 3 different manufacturers. And one manufacturer sells it at $100 per unit, one sells it at $300, one sells it at $900 per unit. And they each sell the same, 3,000 units or whatever a year, so that the total cost of this program is $30 million, plus $5 million, or let's say $25 million, plus the state's going to charge $5 million to administer the program. So you have a total cost of $30 million. The way your bill is designed is each manufacturer pays a prorated percentage of that fee for the program. So each manufacturer would be charged $10 million. Well, the manufacturer selling theirs at 1/9 the cost is going to pay the same as somebody that's charging 9 times the cost. So now you're creating a perverse incentive for these insulin manufacturers to increase the rate so that they are the most expensive insulin in Minnesota. And they can't increase the fee to other states because that would break the U.S. Constitution's Commerce Clause. So they have to direct the fees back to patients in the state of Minnesota. And I came to the Capitol here to lower the cost of care, and programs like this, which are well-intended, will directly increase the cost of insulin for people that are not on this program. And the calculation of the fee does that. And that's one of my biggest concerns about the bill.
Madam Chair.
Representative, yeah.
Madam Chair, Representative Munson. Well, I would disagree with some of the premise and some of the numbers you're throwing around there. But essentially, we're just asking these 3 large insulin manufacturers to pay for their proportion of their share of the market here in Minnesota. And I just want to provide an example for folks. Eli Lilly last year did $25 billion of business. They also paid a federal effective tax rate of $0. And we're asking in this bill potentially a few $1 million for them a year. And so, get out your calculators, do the math. This is a sliver upon a sliver of profits for these companies. So I seriously doubt the assumption that this is going to drastically affect the rates of drugs. And then a second point on that is they're already doing it. Every single day, every single year, these pharmaceutical companies are jacking up the price of drugs and harming Minnesotans. So the notion that we're going to sort of do the bidding of pharmaceutical companies and be afraid that they're going to raise the prices, I reject on its face, and they need to be held accountable. And I just want to underscore again, this is an area where the House and Senate have reached agreement. The Senate plan also asks insulin manufacturers to pay, and so that's actually an area where we've found a way to reach consensus, and I believe helps us move forward. Thank you, Madam Chair.
Thank you, Representative Howard. I just wanted to comment too that one of the things that I learned, or was really brought to my awareness when I went to the community conversations, is that there are many families where more than one person uses insulin. Mm-hmm. And so I don't know how exactly we can account for that in the bill, but having a higher threshold, it sounds like it's pretty high eligibility threshold. But if you've got 2 or 3 people using insulin in your family, that's a lot of money. And apparently something that we haven't yet really tackled too much is the cost of supplies, which is also huge. So it may sound like a person's making a fair amount of money, but if you have this ongoing expense, oh my gosh, it could still be an emergency. So I just wanted to kind of put that out there. We have Representative Grunhagen and then Representative Halverson. Representative Grunhagen.
Well, thank you, Madam Chair. Thanks for your work on this, Representative Howard. And ladies, you have my sincere sympathy for the loss in your family. I have members of my own family, not immediate, but relatives who have diabetes, and 2 of them have passed away, not due to this situation, but I understand the complications that if you don't take care of yourself with diabetes. I also sold health insurance for over 30 years. I have a lot of numerous customers with diabetes. So this is an area of great interest for me. I have 2 questions. First is in relationship to the bills that we pass, and I guess I'd like to ask the Board of Pharmacy if there's a rep here, and I think there is. We passed a bill last session that requires the Board of Pharmacy to create a database of insulin resources. This will help all diabetics find available resources that can help them afford their medicine. That was one provision. I'm just wondering where's that at? And if, to what degree is that being implemented? Or what is the projected date of implementation?
So thank you, Representative Gruenhagen. I see Cody Weiber getting ready to come up, and he's probably the best person to respond to that. Welcome to the committee.
Madam Chair, members of the committee, I'm Dr. Cody Weiberg. I'm the Executive Director of the Minnesota Board of Pharmacy, and maybe I should actually mention that I'm also a type 2 diabetic myself, so just for disclosure. Representative Gruenhagen, I have been working on that program. I've got a lot of resources ready to go in terms of links to other websites. I've actually had, I believe it was representatives of Lilly in my office to explain, give me information about their program. I actually met with Senator Benson on Monday. She asked the same question. And we intend to have this up and running by October 31st. In a normal year, we probably already would have had it up and running, but as members know, there was also the opiate provisions, and those were all effective July 1st, so that's where my focus had to be. But we should have the website up and running on October 31st. You didn't ask about this, but I'd also mention another thing that we're developing, which is a prescription drug repository program. That required us to publish a request for proposals in the state register. We did that on September 6th, and potential interested parties have until the third week of October to respond to that. And I can't really talk with anyone who might submit a proposal directly, but I've heard through the grapevine that there are several health systems and regional pharmacy chains that are interested in that program.
Okay, Representative Gruenhagen.
Oh, thank you, Madam Chair. Oh, thanks for that information. Just to follow up, do you believe, the other provision that was included, and by the way, this was the area I was going to compliment you on during session, Representative or Chair Liebling,
You
were
only
these
one.
two provisions.
Okay.
So I am complimenting you. The other one that was passed this last session, it required health plans that they could not make a profit on insulin by limiting cost sharing to the price of the drug. Any rebates or other cost savings must be passed along to the consumer. So those are the two provisions we passed last session. In your opinion, do you think these two provisions will help people in the crisis of accessing diabetic insulin and other ancillary things that they need in a cost-effective way in the next few months or immediately, or how soon?
So Representative Gruenhagen, maybe that is a question that would be better addressed by one of our two testifiers or Representative Howard. So I don't know. Are you directing it? Are you directing it to Dr. Weiberg?
Yeah, I was.
Well,
I thought he might be in a position to respond if he thought these were going to actually create better access and reduce the cost to nothing or very limited in terms of the people who are suffering from this crisis of access.
Okay, Dr. Weiberg, if you can.
I can respond to that partially, Madam Chair. Representative Gruenhagen, so I believe Representative Howard, then Representative-elect Howard, was the first legislature to approach me about this issue. When we discussed this issue, what I suggested to him was based on a program that went into effect the same month I started as the pharmacy program manager at DHS in 1999. It was called the Prescription Drug Program. It was meant for people on Medicare because Medicare Part D didn't exist then. And that program, people on Medicare paid the first $35 a month. The state picked up the rest of the cost. And I suggested there be some sort of a program where some eligibility was determined and people were, managed through a program like that. But in this case, in a much reduced manner just for emergency supplies of insulin. But then the question came up, what happens when they've exhausted their emergency supply? So one of the things that I suggested was the website that we're going to develop as one tool to give people information about where else they might go. But I think in addition to that, there was an expectation that if DHS was going to do the eligibility, they'd also try to determine if these people were eligible for Medicaid or Minnesota Care or other programs. So I would say the board's website was meant to be one tool. It's, I think, a good tool, but it's not sufficient to cover all the bases. And I really can only speak to that because the Board of Pharmacy does not regulate insurers or PBMs, and so I can't speak to that part of the bill.
Representative Howard, did you want to add to that?
Madam Chair, Representative Gruenhagen, I wouldn't add much more other than, that was a piece of Alec Smith bill that did pass this session, the website, and it was part of the bill. And I think it's one tool, as Dr. Weiberg mentioned, because we do want to connect folks to what resources are out there. But based on conversations with Minnesotans with diabetes and understanding how quickly a crisis might onset, it's certainly not sufficient to address the entirety of the problem.
So did either of other testifiers want to comment on that? Ms. Smith-Holt?
I think, it's a start. The website with the resources is amazing. A lot of people are unaware of a lot of the programs that they could potentially qualify for with the manufacturers. Unfortunately, those patient assistance programs are very difficult to qualify for. More than half of all people who apply for those assistance programs are denied, and it's typically based upon their income. And if we're talking about, the insulin and the cost sharing and the maximum, we're still looking at a great financial burden that some people could be facing, upwards of $100 or more per month they would still be responsible for. And, some people just, that's unreasonable, unacceptable, and they could not afford it.
Okay. Thank you. Did other testifier want to comment at all on this, or you don't have to? Okay. All right. Next question, we have Halverson and then Cantrell.
Thank you, Madam Chair, and thanks to Representative Howard for the additional work this summer on the bill. I was in those meetings as well, and there was a lot of intense and frank conversation. One of the things that I think that we got to at the end of those conversations was an acknowledgement that this is an emergency in Minnesota. A lot of folks, sometimes when we're faced with a crisis, we want to figure out a way that it's not a crisis. When we have to do heavy lifting, it's like, is there a better, is there a way to get around this? And a lot of questions got asked about what could people with diabetes do? What are these additional programs? Who is having trouble accessing insulin? And what we discovered through our meetings, our bipartisan meetings, through traveling around the state, is that this is truly an emergency in Minnesota. Anybody who is doubting it or questioning it anymore is flat wrong. The root cause we have also, I think, made crystal clear. It is the cost of insulin that is being distributed by the manufacturer that is driving this crisis. The solution to making sure that Minnesotans stay alive, Minnesotans living with diabetes stay alive, is to make sure that they have access to diabetes. Make sure that if they're rationing, they're not waiting for their next paycheck. God forbid. We've already heard 2 stories of somebody just saying, I can make it to my next paycheck and get my prescription filled and pay thousands of dollars out of pocket for that medicine. And then, perhaps have to ration it again because the cost is so very high. These are people working full-time in Minnesota. These are people with good jobs in Minnesota. These are people who are working hard to manage a very hard to manage disease. And the question of pharmaceutical companies raising their prices, if they have to contribute to a solution for a problem that they caused, is troubling. I would be shocked if they raise their prices because of something we did in Minnesota. They've raised their prices consistently since 1996. 1,200%. Is there anything else that you buy in your life that has gone up in price 1,200%? I can't think of anything. And that's something that you need to stay alive and to stay healthy. That is what the problem that we're talking about here. And so this is why we have an emergency. And so asking pharmaceutical companies to participate in a solution to a crisis that they caused is vitally important. We heard testimony before we passed the Alec Smith emergency bill in this body last session from pharmaceutical manufacturers who said, well, we just want everybody else to come to the table too. Well, in Minnesota, the House of Representatives and passed a bill that got signed into law regulating PBMs. The PBMs are at the table. Minnesota's major nonprofit insurers stepped up and said, we are going to cap out-of-pocket expenses for people with diabetes because we don't want anybody to die. The insurers are at the table. Physicians are in communication with their patients. Physicians are at the table. The one group who has not come to the table is the pharmaceutical companies. So to say that we need to fear their vengeance on us for taking action to try to save the lives of Minnesotans is really, really crazy. I'm sorry I can't come up with a better word. It's inelegant. And when we talk about cost, who are we trying to save from the cost of this crisis? If people are willing to protect pharmaceutical manufacturers to the expense of everyone else in the system, do you think that they're not pushing premiums up, the premiums that we complain about all the time? It's one of the #1 drivers of why premiums are going up every year. Let's be honest. It's the cost of prescription drugs. That's a driver, a major driver. And they're also going to contribute to additional costs to Minnesota taxpayers. Because if we have 1 out of 4 people with diabetes who take insulin, rationing their insulin in this state, and if that's a conservative estimate, as I agree with Ms. Holt-Smith that it is, we are going to see tremendous additional costs with regard to disability in the state of Minnesota. Diabetes is the leading cause of blindness, of lower limb amputations, of kidney failure, of heart disease in this state and around the world. This is a costly emergency for Minnesota. If economics and protecting people from higher healthcare costs are important to you, solving this crisis needs to be important. And we need to protect Minnesotans. We need to protect them from the high cost of healthcare. We need to make sure that we are promoting optimum diabetes management in Minnesota so that we're not putting people at risk. And most importantly, we need to say that 1 death in Minnesota was unacceptable. And when the diabetes community met with the governor and the governor said, what are the stakes if we don't get this passed before next session? The diabetes community said, someone else is going to die. And you guys have all seen having mothers have to come to try to save other kids' lives, to save other mothers from this is offensive. And it happened again. It happened again because we didn't get to the table and we didn't act. This is an emergency. Let's treat it like an emergency. The right people are at the table telling us what needs to be done. Our job is to represent them. Thank you for all of your hard work and all you do.
Thank you.
To try to make Minnesota better.
Thank you, Representative Halverson. Representative Cantrell, if you can follow that.
Well, I will try maybe not to follow that, but to add kind of my personal thoughts and feelings. Thank you so much for your beautiful words, Representative Halverson, and thank you, Madam Chair. Representative Howard, Madam Chair, Representative Howard, we had a community conversation in my district, right, in Burnsville, around insulin accessibility, but around pharmaceutical accessibility as a whole. And I think you'll remember a community member of mine, her name is Carolyn, She worked for the United States Postal Service for 30 years. She was promised at the outset of her career stability in retirement, stability both financially and stability in terms of access to health care. She's somebody who lives with diabetes, and because the cost of her insulin has risen so exorbitantly, she had to come out of retirement after being a lifelong public servant to work for DoorDash, to run food to people because she needed extra money in order to afford this life-saving medication. Now, I want us all to be clear about what's happening here in the pharmaceutical industry, especially around insulin, but around a lot of other drugs as well. They don't have to play by the rules. The U.S. government has said, you don't have to play by the rules. Every other segment of our economy needs to play by the rules. You can't price gouge citizens. If you do something that leads to someone's death, you're going to be penalized. But the pharmaceutical industry, they've been given a blank check. The government, as far as they're concerned, has said, go ahead, raise your prices as much as you want. And oh, what happens if a state government or if somebody tries to rein in the cost of these pharmaceuticals, many of which had been discovered and many of which these companies had no role in creating whatsoever? Well, they say, hey, we're going to raise the cost of your drugs. Well, guess what? The pharmaceutical industry, because of their unfettered greed, their blank check to bankrupt the American people and the people of Minnesota, they're already raising the cost of our drugs. And it's high time that we penalize them for their unfair, as far as I'm concerned, uncapitalistic and un-American practices of harming patients and prioritizing their own profits, their own profiteering, and the increase in their shareholder or their share value to please whoever holds their shares rather than actually protecting the patients, without whom they wouldn't have an industry to begin with. So I want to thank you both so much, all of you so much, and every advocate in this room for the fight that you have brought to the legislature, because without you, the pharmaceutical lobbyists would be the ones who would be trying to steer the boat on this. But because of you, this is truly centered around people, and with that, you are actually driving this conversation in a way that will save people's lives. So I thank you so much for everything you've done. Sorry we didn't get this done last session. It's appalling, but God is my witness. We will get this done next session.
Thank you.
Thank you, Madam Chair.
Thank you, Representative Cantrell. Representative Munson.
Thank you, Madam Chair. Representative Howard, I have a few more questions on the new version of the bill. We talked about it on the floor and again during debate during the last day of our special session when a minority of us here at the table voted for the bill, but the bill didn't pass. And that's because we were going to pay for it out of the Healthcare Access Fund, a fund that was set up specifically to give access to care for people that can't afford it. I'm again concerned about increasing the cost of insulin in Minnesota by pushing this fee on the manufacturers. I think it's short-sighted to think that they are not going to increase the cost on us as consumers. But in the bill, when I look under eligibility for this program, I know that your testifiers had mentioned that we need this insulin for type 1 diabetics. And this bill doesn't say that. It says it basically would apply to anyone, assuming they have a prescription, so a doctor have to write them a prescription. But is this going to apply to all diabetics? Because it's my understanding that 90 to 95% of diabetics are type 2 diabetics that are not insulin dependent. So does this cover all diabetics, or is it just type 1?
Representative Howard.
Madam Chair, Representative Munson, and again, perhaps a doctor or one of our Minnesotans with diabetes would be better to answer this. But I mean, as I understand, type 2 diabetics absolutely may need insulin. It's not the same relationship as a type 1, but this would absolutely apply for type 2 diabetes because that's important as well.
And I don't know, if you didn't actually use insulin, I don't know why you did the program. So obviously it only applies to people who need insulin.
Well, Madam Chair, the whole reason why we're doing this is not to bring down the cost of insulin nationwide. This is to give emergency access to people who need it. And I think, testifiers had talked about it being life-saving drug. And for the overwhelming majority of type 2 diabetics, it is not something they need to live. It is something to help control diabetes. And I know we can have a debate on this in a discussion, but over the interim, and talking to doctors and pharmacists about diabetes, it came to my attention that the older style insulin, the human insulin, does work and it could be used in an emergency. And in way of testimony here from an endocrinologist that's practiced for 35 years who called me when he heard about this coming up in the legislature to discuss that there is emergency insulin available in the private market that someone can use with doctor instruction to, that's more readily available than going through the state of Minnesota for a program that can save lives. And in his opinion, that no one should be rationing insulin because they can't afford synthetic insulin for a few days or a short period of time. People's lives change. You know, I went from, you know, working in a great job to dragging dead pigs out of a barn in a matter of a year because of the recession. Things change. It's important to have a plan in place to what to do in an emergency situation so that you don't have to ration care. No one should be rationing insulin. And in his opinion and many others, that the other insulin that's available in the market privately without a prescription over the counter, you know, over 4,000 retail locations around the country on the weekends too, is a possibility for life-saving insulin. And I think it's important to have an honest discussion when we're talking about an emergency program. We're not talking about lowering the cost of insulin and trying to go over this bigger fight, which most of the solutions to lowering the cost of insulin are done at the federal level. Reimporting drugs, allowing new manufacturers to come in and compete against the existing ones. That's really important. But if there's 200,000 diabetics in Minnesota and you're going to include everybody in the possibility of everybody in this program, if 1 in 4 are rationing insulin, that's 50,000 people. That means that this is going to be a $100 million a year program. And again, the insulin manufacturer who lowers their cost is penalized under your assessment of this fine. And that's not the way we should be working to lower the cost of insulin. So I'd like you to discuss whether it's all diabetics that would be in this program or just type 1, the people who are absolutely dependent on it and would need emergency insulin, not convenient insulin or something to help treat their existing disease.
All right, I'm going to go to Representative Halverson, and I don't know if our physician here at the table, Representative Morrison, might want to comment on that too. Maybe, Representative Halverson, should we let her comment on because comments were made about type 2, and I happen to have one of those close to me, and I know that's not right. So if you would, Representative Morrison, just give us the scientific piece here.
Sure. Thank you, Madam Chair. You know, I think it's really important that we not practice medicine here in the legislature, especially when we don't have the facts behind us. Type 1 diabetes and type 2 diabetes have to do with when you're diagnosed and the mechanism of action for your diabetes. There are people who have type 2 diabetes who require insulin to live. So this bill is designed for people who have diabetes who need insulin in an emergency situation. It's really not relevant, this is not a convenience thing. This bill is designed to help people in an emergency where they require insulin.
Thank you. And Representative Halverson.
Thank you, Madam Chair. And we are so fortunate to have physicians at the table with us to give us good medical facts. I'm incredibly concerned about what I have heard from Representative Munson. I'm incredibly concerned about the letter that was included. That's from a physician in Arizona, not in Minnesota, and I believe who is connected with some other political organizations like the Heritage Foundation or Heartland Institute. So we need to be aware of who's giving us medical advice. And Representative Morrison, Dr. Morrison, couldn't be more right. It has to come from physicians here in Minnesota. And an understanding of what it's like to live with diabetes has to come from people with diabetes. I have diabetes. I have type 1 diabetes. People with diabetes live with misunderstandings of our illness all the time. And boy, do we get advice, right? And we get questions, should you eat that? We get questions, I mean, it's sort of like, trust me, I know this. I know what impacts my blood glucose every single day. And it's really complicated to manage, and it's really about each individual. It's not about, these blanket proclamations that go and check out Walmart insulin because it's a solution. That is not a solution. People have died trying that solution to stay alive. This has also happened in the last year. And so to recommend this as a possible solution to Minnesotans is very uninformed at best. To double down and say that people who need insulin, if for some reason you can't afford $30,000 worth of insulin in your life, the insulin that keeps your blood sugar regular, that keeps your diabetes optimally managed so that you know that you have a future where you can go for a walk in a park with your grandchild and you don't have to use a wheelchair because you lost a limb, to know that you can read a book to your child and not have to have them read it to you because you lost your eyesight, to not die of a heart attack because your blood glucose was not optimally managed. These are the choices that you're asking Minnesotans to make by saying, go to Walmart and buy insulin for $25. That is a terrible choice. We've defined the problem, members. The problem is insulin is too expensive. The modern insulin that we are prescribed, that doctors prescribe, the best course of care. And I will tell you, diabetes has gone through rigorous reforms with regard to optimal care and best practices. It was one of the first issues that was tackled by ICSI, maybe 10, 20 years ago, in terms of how do we make sure that we are getting the best results for people with diabetes, because it is so costly. It's costly in lives and it's costly in dollars to not have diabetes optimally managed. And so the clinical guidelines around diabetes care are not, here's hoping you can afford it, and if you can't, go get Walmart insulin, go get outdated insulin. The optimal approach is to make sure that we're seeing our doctors regularly, that we take our medication on a regular basis, that we get regular exercise, and we get our feet checked, we get our blood pressure checked several times a year. And we take insulin that is modern and that works. That Walmart insulin, yeah, I mean, it's better than dying, but there's no guarantee you won't die if you take it. There's definitely no guarantee that you're going to get optimal blood glucose control. In fact, there's a guarantee that you won't. Your blood sugars are going to be higher and lower all day long. We need insulin that is going to make sure that our blood sugar does not spike and fall all day long. And even when we're doing everything right, it's still going to happen. You get the flu, what happens to your blood sugar? For some of us, if we exercise like we're supposed to, we get a crash. Some people go high. It's like our bodies are all, so we are all fearfully and wonderfully made, right? It's like we are all very unique. Don't pretend to understand what we live with every single day and then legislate based on that. We legislate based on representation. Listen to the people who live with this disease every day. Listen to the people who said this would have kept my kid alive. Listen to the people who say, I don't want to live a life that's filled with disability. Listen to those people. Those are the right questions to be asking those people. And I guess I'm those people. So forgive my frustration. And I give a lot of people a lot of room for not understanding the disease. It is complicated. We ask questions all the time. We ask questions of each other. There's a reason there's a community here. We need each other.
Thank you, Representative Halverson. So members, I have on the list Representative Knorr, Haley, Schultz, and Grunhagen. We'll try to get through those, and then I think we're going to try to move on to our next phase of our hearing here. So just to let everyone know who I've got on the list. Representative Knorr.
Thank you, Madam Chair. Thank you, Representative Howard, and to the testifiers, Nicole and Cindy. The stories that you have shared with us resonates with many Minnesotans. I've got a friend who just at the beginning of this month suffered a stroke because she could not afford insulin. a well-functioning Minnesotan is now in crisis, which we could have taken care of this issue if we passed the Alec Smith Act long time ago. No doubt, the cost of insulin has risen steadily and steeply. That is costing the lives of many Minnesotans, particularly those who are underinsured and those who are uninsured. There are many people that we don't know about who are suffering today because we don't help those individuals who ask for us to come here and address a crisis that exists in our community. You know, the supply chain of insulin from the manufacturers to the PBMs, to the insurers, to the pharmacies, they all have a responsibility. The greed from the manufacturers because they only work for their shareholders, not for the people who need insulin or medication. We can no longer sit back. We have got a broken system, people with greed taking advantage of those who need help now. We got to address that. It's a fact. No one should die because they could not afford insulin. No Minnesotan should die ever because they could not afford any life-saving medication. We have got a duty to Minnesotans. We need to act now. We need to address this issue. It can't wait for tomorrow. Our actions, what we do today, will speak louder to Minnesotans that we care about them. We care about those who have their loved ones who they lost. We care about those who are suffering today, and we can provide the help. This is not social medication or socialist medication that people talk about. It's caring for Minnesotans who need help now. So I think we can act quickly and address this issue as required.
Thank you, Representative Noor. Representative Haley.
Thank you, Madam Chair. Thank you, Representative Howard, for all your work. And to the mothers, as a mother who has buried a child, there are no words to express our loss for what's happened to your families. But Representative Howard, I have a couple technical questions. And one is regarding eligibility. Since we do have insurance companies in the state of Minnesota who have come to the table and stepped up with $25 costs and copays, how does that impact your proposal, and would it then apply for folks that are uninsured? That's my first question. Then my second question is regarding implementation. You know, we focused on the emergency nature of this crisis, and that when I read your bill, a patient would go into a pharmacy, would have to fill out paperwork. DHS would take 31 days to decide on eligibility. So I'm concerned about how does that meet an emergency need, and if you could kind of compare and contrast the Senate bill, because I think we've come together on this idea around the importance of how do we get insulin to people right away when it is an emergency. So if you could talk to those two issues, I'd appreciate it.
Representative Howard.
Thank you, Madam Chair. Representative Haley, those are both good questions. To the first question on eligibility. So this bill is structured, again, to target the folks most, we think, in need or could be in this situation. So that would be folks that are uninsured and also potentially folks that are on these high deductible insurance plans with out-of-pocket costs of upwards of $5,000. Now, because of the actions of capping out-of-pocket costs, there's a set of Minnesotans that probably would not be eligible for this program because they're on an insurance program where they're able to afford their insulin with a $25 copay or a $0 copay. I believe 3 out of the 4 large insurers have made that move. Although, so there's a segment that 3-4 months ago probably would have accessed this program that now wouldn't, but we still know that there's a large group in the there's an employer-based insurance that might not necessarily have that same copay situation. They still might be in a high deductible plan. Those folks would still be able to access the program, and folks that are uninsured are a huge need in this program as well. And in general, what is that target universe of folks we're talking about? That's something that we are working to assess, and I think soon we will through the fiscal note process, because that's an important element of this. Who are the folks most in need? And so it's a good question. And your second question about how soon to get medication into the hands of those in need. And this was all through the process, kind of the million-dollar question, because we know that there's an emergency need. How can we do this in the most efficient way possible for the patient? And the bill today has an improved, streamlined process. So you would act, a Minnesotan who would bring in a very basic form attesting to their eligibility to the pharmacist, and they would be presumed eligible at the pharmacy level and receive a 30-day supply of insulin that day from the pharmacy. We would, the form would then be sent under the current bill through DHS or some mechanism to have that eligibility more rigorously checked. And if they qualify, they would be approved for another 60-day supply of insulin. And that's the phase 2 where we also want to, connect folks then to longer term options. And this speaks to how I think there are ways to work together to find a path forward. You mentioned the Senate proposal. As I understand, it's not really an emergency program because of the steps. So a patient would have to apply through a program on a MNsure website, as I understand the Senate proposal. They would then have to go to a doctor, get a appointment with their doctor with this sheet of paper that they're eligible. The doctor would then have to send that to a drug manufacturer. The drug manufacturer would send the supplies back to the doctor, and that's how medication would be supplied to patients. And so, I mean, on its face, it seems like a many week process. And during the Senate hearing, we also heard there may be issues with doctors themselves being the responsible party to provide the medication. We think the pharmacy makes more sense for that. But long story short, the concept, address the emergency need while also finding a way to direct people towards long-term options, that makes sense. And that's where I think a productive conversation can develop between the House and the Senate.
Madam Chair, can I have a follow-up? Yeah. I just would encourage continued work on both of these proposals. I think you said you were encouraged, by the conversations and the fact that I think the citizens of Minnesota should know that both the Senate and the House are working diligently on a solution. There's steps in the process on both proposals, I believe, and we think we need to look at what it will take to actually implement. And I know in your bill, you're looking at maybe July of 2020. That's almost a year from now. So if there's a pathway there that we can have a solution that we can implement more quickly, that's efficient, for the people in need, that would be great. But I also have a question on the high deductible, because again, my understanding is, so are they carved out of your proposal, or they would be served by our insurance companies who are providing the $25 insulin that doesn't, regardless of a high deductible or not?
Madam Chair, Representative Haley, I want to make sure I understand your question. This is meant to apply to somebody if they're on a plan that has that high threshold. So if you were on a plan that capped their insulin at a $25 copay, you would not be eligible for this program.
Okay. So members, other members are now adding their names to the list, and I just think we have to cut this off at some point. So I have on the list, when I said we were going to stop after these folks, I had Schultz and Grunhagen. Now, Representative Grunhagen, you've already asked a question. I don't know if you want to cede your time to, and Representative Munson, you've asked twice.
Well, Madam Chair, I
and
was
we've
called
got-
out by name by another
Well,
member of this committee. I feel like I have a
Representative
chance to,
Franson
should have a
also
chance to respond.
Representative, well, we can't go back and forth here forever. I think everybody's case has been stated pretty well. Representative Franson also has a question, so let's go to Schultz and Representative Grunhagen. I don't know what you wanted to ask, but, she hasn't had any
I just
opportunity
got a
yet.
statement. I'll just make a statement. It's short.
If it's real short, and then, because I
I'll
think
keep
you've
it
had
real
one
short.
opportunity before, and this will be your second. Representative Schultz.
Thank you, Chair. I will try to keep this brief as well, but, I don't think we should all say that we failed here, because the House and the DFL passed this bill earlier this year, and we tried desperately to get the Senate Republicans to support this bill and pass it, and we failed to get them to support it and pass it with us. So we should be careful when we use the word "we." because I know many people in this room support this bill and tried to get it passed. Secondly, I think that this conversation is a great conversation, but what I hear from Republicans consistently is that they are fine, they are okay with having health care be rationed by income or by ability to pay. And many of us here are not fine with that. We believe health care is a right and that we shouldn't give one type of medicine to people who are poor, old generation medicine that doesn't meet the clinical guidelines, and that people who can pay get the best medicine. So this is a message I hear that we need to tackle overall, not just with insulin, but this rationing by income has to stop. And here in Minnesota, that would be a benefit to people who lived in Minnesota. We could make sure that everybody has the best possible health care, and it shouldn't be based on ability to pay. So we need to rectify that somehow, and that's a bigger conversation. But, people, just because they can't pay, they shouldn't just get leeches or bloodletting. They should get the latest medicine, the best technology that's based on clinical guidelines from our trained physicians. And so when I hear some individuals at this table talk about older type insulin that's not the best practice, that's not a solution. And we need to think about how we can reform healthcare in the state of Minnesota so we're not rationing by income or ability to pay, and that everybody has access to the best possible medicine to improve their lives, to extend their lives, to save their lives. And that's what's important. And that's a conversation. We don't really talk about that philosophical issue of whether or not it's okay to ration by income. And I think that's where we need to start when we talk about healthcare reform in the future, is what does healthcare need to look like and how do we pay for it so we don't ration by ability to pay.
Thank you. So Representative Gruenhagen, what if we just go to Representative Franson and then let her ask her question? Because if she has a question, it's likely to take a little time, and then we'll let you have a very brief statement, and then we'll
the end.
be done with this.
Okay.
And then I'm going to
Ladies
wrap
first.
it up at the end. Well, just she hasn't spoken yet, so Representative Franson.
Thank you. I've been very quiet. It's a very deep topic, and I share. Thank you to the moms up there, and Representative Howard, I agree with you. We should never ever do the bidding of pharmaceutical companies. So thank you for that statement. We should never do that. And Representative Morrison, you're absolutely right. We should not practice medicine here in the legislature. You're absolutely correct. And we should never mandate a product on its people. That should be left between the doctor and the individual in the clinic room. So I just want to, this isn't just to get political though, but I do have to get a little bit of truth on record. We're hearing like nothing was done last year. Republicans didn't offer solutions. It was the Democrats took care of that. And during this end of session there, Representative Hamilton did offer an amendment to use healthcare access funds, since that fund is not going away, and the legislature voted to continue that 2%, well, it's been lowered down, I think, to 1.8% provider tax now. We took that vote, Representative Howard, I'm sure you remember because you spoke against the amendment. But we thought if, this being an emergency, let's take care of it now. Let's use healthcare access funds. And that is still, I think that's still on the table perhaps to continue having that discussion. But House Republicans did vote for that. It was voted against by the Democrats because it was made certain that we wanted to hold pharmaceutical companies liable. They needed to be at the table. We needed to punish them. I just want to get something done for the best of the people, so it's not to get political, but I did need to get our side out on the table as well. A question about pharmacy participation. I'm going to have pharmacies, I'm sure we're all going to have pharmacies asking how is this going to work. So could you walk us through, is this something that they'd be mandated to participate in? How do you see getting buy-in from the pharmacies? And then the bill doesn't explain the reimbursements that would take place for those pharmacies as well. So if you could just help us with that, that'd be great. Thank you.
Representative Howard.
Thank you, Madam Chair, Representative Franson. And Just to the first statement, I just want to reiterate one piece of on the funding that is now different from the end of the legislative session. We now have consensus with the House and Senate that insulin manufacturers should be the ones paying for this program. And so that was contentious at the end of the last legislative session, but I'm hopeful that that won't be contentious going forward now that we have agreement with the House and Senate about who should be paying. To your question on pharmacists, it's a really good question. We've worked with the Board of Pharmacy and in consultation with pharmacists on this program because we want to make sure we have a program that works well on their end. And reimbursement is really important. So that's why we've structured this program in when a patient will go into the pharmacist to get their supply of insulin, the pharmacist will be reimbursed directly. And that will happen through the coordination of a pharmacy benefit manager that will essentially be handling the administrative function of this program. And so we believe that it will work well for pharmacists and utilize the existing network so that Minnesotans can go to the pharmacist they're familiar with and get their insulin.
Really quick follow-up, Representative Franson.
Thank you for indulging me, Madam Chair. And to Representative Howard, what rate would that reimbursement be? Would it be the true cost of the insulin, or are we looking at a negotiated price? I heard you mention PBMs. There's a lot of distrust with the PBMs currently, so.
Yeah, Representative Howard.
Madam Chair, Representative Franson, good question. We've included legislation in the bill that would prevent rebates so that it would be the true cost.
Okay, and Representative Grunhagen.
Oh, thank you, Madam Chair. I'll just make a statement to give you food for thought, Representative Howard. When I look at the bill, I think we're asking DHS to manage this program. And if we look at the track record of DHS, it's less than great, to say the least. Currently we have top executives leaving the DHS.
Representative Grunhagen, I'm indulging you to do this, but if you're going to use this to make a big statement about another topic, I'm going to cut you off. So if you have a question or something short, please ask it. But I'm not going to allow you to drag us off.
I'm just saying, Representative Howard, look at DHS's track record versus the private sector has some things in force. And I think if we work with them, we might be able to streamline some of that stuff. And when we get DHS involved, a lot of times things don't go very well. I have customers who have a lot of problems paying their copay or affording their drugs. One of the things I use is senior linkage. They've been very good about knowing about programs that have been available with pharmaceutical companies or other ones available and helping patients out with their costs. So explore those avenues versus giving DHS control over this. I think the access to insulin will be much quicker that way, and we all want diabetic patients to get the access that they need. None of us disagree with that. But I don't know if DHS is the best way to go based on their track record. Thank you, Madam Chair.
Representative Howard.
Madam Chair, Representative Grunhagen. What I heard you saying is let's look to the private sector. That's looking to the current system. In the current system, Minnesotans are dying. So we need to create a program that creates a safety net so Minnesotans get insulin when they need it. And to the question about DHS, I want to be clear, there's a very limited role of DHS to play in the administration of this program, and that's by design. We didn't want to create a new infrastructure. We want to use the existing networks in place. And so really DHS would be contracting with a pharmacy benefit manager to administer a pretty basic benefit for Minnesotans as they go to their pharmacist to get their drugs. The experiences and everything we've heard from Minnesotans with diabetes tell us we need this bill. We cannot rely on same old, same old. We need to pass the Alec Smith Emergency Insulin Act. Thank you.
Thank you, Representative Howard. I just want to note, too, the senior linkage line is run by DHS. So
that's good to know. I didn't know that.
Yeah, I don't think that we're giving
Well, I was
for
given
that.
one copy.
So I just would like to close off this part of the.
Madam Chair, can I at least respond since I was called out
No,
by name?
no, Representative Munson, because you've spoken twice.
And-
We've gone back and forth on this. I think you guys can take it offline.
A
now.
nationally recognized physician
Yeah.
submitted testimony
You've
that was
got
it was
it.
completely
You
discounted
mentioned
because
it.
he lives out of state,
You
even though he's
mentioned
testified in
it,
front of Congress.
Representative Munson, we've got it in our packets. Thank you. It is so noted. So I just really wanted to finish this off by just noting that, as I understand it, there's been some discussion between the Speaker of the House and the Majority Leader in the Senate about establishing, how do we move forward from here? I think that's kind of on everyone's mind. We recognize that there may be further tweaks that we need to the bill and a lot of your input and, comments on the draft are very much appreciated. This is a way we get legislation that works well, is when people come together and they look at it and they say, what about this and what about that? How can we make this work better? So I'm hopeful that what we're going to see is the House and Senate appointing, even though we're in the interim and it wouldn't be an official conference committee, but appointing people to a conference committee-like group that would have actual authority to come to an agreement. Now, we had legislators working on offline on a work group, which was very much appreciated, and Representative Howard has mentioned some of the changes and some input that was very valuable. But at this point, I think we need to come to an agreed upon piece of legislation so that the governor can go ahead and call a special session and we can enact it. So hopefully the next step is for the House and Senate to appoint people and perhaps for the governor to appoint people as well to have a discussion in which we can come to an actual agreement on a bill that would be agreeable to most of each body and that we could move forward. So that's kind of I don't know a timeline for that. I don't know if any of us in the room have a timeline, but we're hoping that that can happen rather quickly because as we all recognize, this is really an urgent situation. It's an emergency for many Minnesotans, and we want to move forward. We want to look forward, not backwards, and do this as quickly as we possibly can. So thank you to our testifiers and to all the advocates in the room. You are, this is, we know that this is a lot of work on your part, and we really appreciate your input. And this should be nothing about us without us, as they say, right? This is really important that your voices are at the table and that you're informing us and bringing this forward. And from my limited experience listening to Minnesotans in a few of those conversations, you're doing a great job bringing forward those voices. So our great appreciation for that. Thank you. So we're going to move now to this next phase of our hearing and bring up, we're going to hear more about what's been going on with some of the health plans on the insulin copays so that we can just get an update on that and hopefully we'll have a little bit of time for some questions and discussion around that as well. So first we're going to invite Jay McLaren up to the table. And I've asked each of these plans, we've got Medica, HealthPartners, UCare, and BlueCross, BlueShield, and I've asked them just to give us, start us off by just giving us a very brief explanation of what they have done around this issue, and so that we can get some little bit of context and a little bit of compare and contrast. So, Mr. McLaren, welcome.
Thank you, Madam Chair and members. For the record, my name is Jay McLaren, and I'm the Vice President of Public Policy and Government Relations at Medica. And thank you again for the invitation to testify in front of your committee, Madam Chair and members. Obviously, the soaring costs of insulin are a serious issue for patients with diabetes. This is a big issue both nationally and obviously at the state level here in Minnesota, with more than 30 million Americans living with diabetes and also more than 400,000 Minnesotans living with diabetes. Due to the attention that this issue has drawn in the media and here at the legislature, our executive team came together in July of this year and had a discussion of what can we as an organization do to help make sure that all of these things that we are seeing in the newspaper and the tragic events that have occurred here with rationing, how can we prevent that from ever happening again? So our leadership team came together and made a decision to make an investment in our members here in Minnesota to make sure that co-payments for all of our fully insured members in Minnesota, so that's everyone in the individual market and through group coverage that we are fully insuring, are going to pay no more than a $25 co-payment for a 30-day supply of insulin. This is something that we did that applies to all of the insulin on our formulary. It's not exclusive to any specific product. It is something that we did not increase our rates for next year. And again, is something that we did in order to make sure that the tragic events that we've heard about would never happen again in our state. We believe this investment will make a meaningful difference by decreasing the financial burden on our members with diabetes. I want to give a special thank you to the Department of Commerce. I and others at Medica reached out to them 7 to 10 days before our announcement to talk through the change that we'd like to make to our products for next year and work through with them a timeline and a process for us to do that while we were in the middle of them reviewing our products for next year. It's a very busy time for them. And they worked and were very flexible with us to accommodate our changes to our products for next year. And it was some extra work on their part. So a special thank you to the Department of Commerce. Since our announcement on August 5th, we have obviously received a lot of positive feedback in local media and from government officials and others. The most rewarding feedback that we have gotten are from our members and from our family members and from people in our community that have come up to us at different events and thanked us for the decision that our organization has made. Again, we were very deliberate in doing this and wanting to do it to make sure that people won't have to find themselves in a situation where they are rationing their insulin. And we are very humbled by the impact that this is going to have on our members. I'll conclude by saying that we obviously know that this doesn't fix the underlying issue, which is the cost of insulin. You know, I mean, this is something that helps with how much people are going to pay for their insulin out of pocket, but it doesn't address the underlying cost, which I don't need to educate the committee on. So we look forward to working with this committee and others in the legislature on that issue and other issues that aren't fixed by our decision, which is the uninsured population, and then also folks who don't qualify for this program who have their insurance available through a self-funded employer. So we look forward to working with this committee and the legislature on those issues. This concludes my testimony, and I'd be happy to answer any questions, Madam Chair and members.
All right, thank you, Mr. McLaren. I think what we'll do is let all of the different companies testify. If you would stick around in case there are questions. I know I already have Representative Loeffler on the list. And Representative Loeffler, are you okay holding your question until we get the 4 companies to let them get through it?
Madam Chair, I'd be glad to wait. I just would like to hear from all 4 of them on just a technical issue.
Okay.
On the percentage of people that they insure that would actually be affected by this, because my understanding is that the majority of people with employer-based coverage would not be affected by this. And I think the public needs to understand that.
Okay, so that makes sense. So if each of you could mention that maybe when you come up, it would be helpful. So the percentage of your people that you insure who would be affected by this, because as Mr. McLaren mentioned, the people who are self-insured are not,
Right.
It doesn't affect everyone in the market. So I don't know if you have that as a percentage, Mr. McLaren, do you?
We can supply that to the committee, Madam Chair and members. So obviously, Representative Loeffler Madam Chair and Representative Loeffler, as you know, a large percentage of the people in Minnesota get their coverage through a self-funded employer. And the reason that we can't guarantee that this is going to be offered through them is because they are the plan sponsor. They are the ones that are at risk, and they're the ones that make the decisions on the health insurance that they offer their employees. So we can't guarantee that.
Right, okay. Thank you very much. All right, I think that Barbara Cox from HealthPartners is next. Welcome to the committee.
Hi, good afternoon. My name is Barbara Cox, and I'm testifying on behalf of HealthPartners. HealthPartners, as most of you know, is an integrated care system with a health plan, clinics, hospitals, and pharmacies. So we have a uniquely broad view of the impact of drug prices on our members. And HealthPartners is doing a lot of work in this area. We have the International Diabetes Center at Park Nicollet Methodist Hospital. MTM, we just testified last night in the AG's task force. I understood the question for today was coverage, so that's what I'm focused on for this testimony. So in current state, HealthPartners currently offers plans in all of our commercial market segments. So that's individual, fully insured, which is small group, and large group and fully insured, for a high-low copay of $25 at the high and $5 at the low for insulin. I want to note that this coverage has existed before the recent attention on insulin. So this isn't a new program for us. This is something that we had. Now, going forward, in 2020, we are working now on a systematic approach so that in 2020, all of our fully insured members will have access to insulin for $25 or less per month. And while we work, like Jay said, to implement this change, we urge you to continue your policy work to lower the cost of insulin, which is in fact the underlying issue. Thanks.
All right, thank you very much. Please stay around in case there are questions. Okay, UCare, Ghita, Worcester. Welcome.
Well, thank you. Thank you, Madam Chair, members of the committee, and thank you for saying Worcester correctly. That's unusual.
I lived in Massachusetts for a long time.
Probably said it better than I did when I met my husband. UCare is a health plan currently serving over 430,000 members in Minnesota, but only of that membership, 31,000 are on MNsure today, and that is our only individual and family coverage at all. So answering the question, all of our members will be able to benefit from the $25 copay, but we don't have any other lines of business that aren't affected simply because of who we currently cover. In the coming week, the Department of Commerce is going to be issuing the rates, and although we can't talk about them today, what we saw happen in early summer after we had filed our rates in spring was that there was a notice from the IRS that gave us the ability to do something different on HSA-compatible plans. And for the first time, we were going to be offering that plan. What we were able to do was to work with all of our stakeholders and allow that the $25 max out-of-pocket on insulin for all of our covered formulary would be able to be put in place for the 2020 contract year. We also thank the Department of Commerce for their quick work on this. We knew it was an important topic. And I think one of the pieces that we can acknowledge here, there were comments during the discussion about individuals who have no coverage or are just getting by. We see people coming into our state public programs and into our Medicare product that have been rationing or doing without, and the medical care that they were receiving has been compromised when they come on. So all of the issues about this were incredibly important for our organization. It did not change our premium rate. We were able to work through how we could put this in place because we knew it was an important topic to include for our membership. And we really support what you're trying to do on the emergency care, going back to the fact that we see the whole care delivery for individuals with diabetes, and the importance of the insulin coverage to this, and the care that's provided to by the physician community, because you have to look at this in a holistic approach. So thank you for asking us to testify today.
Right. Thank you very much. Blue Cross and Blue Shield, Lynn Nelson.
Good afternoon. Thank you for having me here today. My name is Lynn Nelson. I'm Director of Legislative Affairs for Blue Cross Blue Shield of Minnesota. As a nonprofit taxable organization, Blue Cross is the largest health plan in Minnesota, covering 2.9 million members. I applaud the committee's efforts to take a deeper look at the underlying costs of care, specifically prescription drugs, and in this case, insulin, as part of our broader efforts to rein in healthcare prices that place a tremendous financial burden on our families throughout the state. Blue Cross and Blue Shield of Minnesota plans to offer insulin coverage to thousands of members with a zero cost sharing. And to answer your question, Representative Loeffler, in the area, in the markets that we are covering, is about 260,000 members at this point in time. Obviously, that can change after January 1st as members fluctuate between plans. Beginning on January 1st, 2020, Blue Cross and Blue Shield will include Tier 1 and Tier 2 insulin options as a covered benefit with no member cost sharing in plans where Blue Cross sets the health plan benefits and manages the financial risk, referred to as commonly as the fully insured market. These include plans offered as individuals and families both on MNsure and off MNsure, small employers, and most large employers. The insulin benefit change of Blue Cross applies only to members in the commercial fully insured market. Many large employers and most national corporations set their own health benefits. This is under the ERISA law and permitted under ERISA law, which Blue Cross then administers with access to the Blue Cross provider network. These employers are referred to as the self-insured market, which you've already heard. Blue Cross has the ability to administer a similar insulin benefit to those members if they ask for us to do that. All eligible individuals and employers will have this benefit change go into effect January 1st, 2020. Our first responsibility is to do what we can to improve the health and financial stability of our members. We felt a responsibility to address the skyrocketing price of insulin with the options we have available. Our action will provide some measure of financial relief to many of our members who live with diabetes. However, the problem is much larger than insulin. More must be done to hold the pharmaceutical companies accountable for the astronomical and arbitrary prices they set for medications that treat a range of serious and chronic issues. With no oversight or accountability, these companies will continue to charge whatever they want. As a state, we need to work together and address the root causes of what is making affordable treatment out of the reach for far too many people. Thank you.
All right, thank you very much. I have a list here, and Representative Loeffler, you already asked your question, or did you have more?
Well, thank you, Madam Chair. I just wanted to point out to the people who are watching us, because insurance is really complicated, as we all know, and the insurers did a really nice job of explaining what they've stepped up to do, and I really appreciate them stepping up and offering more affordable options. But as they stated, the majority of our employers do it in a self-insured way, which people don't need to understand, except that if you're getting your coverage through an employer and you're insulin dependent, it would probably be worthwhile for you to go to your HR department or the president of your company and say, my life depends on this, and I understand that your insurer, the insurer we've been with, is offering an affordable option for insulin coverage, and I hope you will step up and take that when you decide on our benefit package for next year, because it won't be automatic. And I think that the more that we can get people covered by affordable coverage, the more we're going to affect our ability to prevent rationing and death and disability. And I think that's important. And I look forward to helping address and working on some work to address other drugs that other people with chronic illnesses have that also threaten preventable disability and death. But I think this one is important, and I think if we can get our self-insured employers to step up, we'll have a state with really broad coverage that'll marry well with the Representative Howard bill.
Thank you. Representative Schultz.
Yes, I just have a question. Thank you, Madam Chair, of the insurers that testified here today. I'd like to know what strategies they have pursued and are thinking about pursuing to negotiate drug prices besides using PBMs. I know that they negotiate with other providers like hospitals and clinics for reimbursement, and I'm interested to learn and educate the public about how they can negotiate lower drug prices. And secondly, why stop at insulin? If you're really concerned about the cost of insulin, why stop there and creating special programs?
Yeah, and thank you all for coming to the table. I was going to suggest that if you all felt good sitting next to each other, which I think you do, and we need one more chair there. And that's great. So if you all heard the question, should we just, I don't know, Mr. McLaren, you look like you're ready to answer. Go ahead.
So, Madam Chair, again, for the record, my name is Jay McLaren with Medica. Madam Chair, Representative Schultz, I think one thing to understand, particularly around how our business operates, is that we do, as everyone in the committee knows, contract with a PBM to manage our pharmacy benefit for our members. The value of using a PBM is that they basically consolidate the purchasing power for any pharmaceutical manufacturer that wants to participate in the American market needs to go through a PBM here. And quite frankly, when they have to go through those PBMs, that gives them some purchasing power to be able to try to reduce the cost compared to what others may be able to do on their own. So I think for us, I think you raise a good point of what are some of the other strategies. I think for us and the lives that we would bring to the table with a pharmaceutical manufacturer, they're not as large as the number of lives that the PBMs bring to the table with the pharmaceutical manufacturer. So that shouldn't prohibit us at looking from different strategies to try to address the cost of insulin. But I think there are some economic realities that make it extraordinarily difficult to get a better deal in what we're getting through the PBMs.
And so there were two questions in there, but maybe we should let them all answer the one and then maybe restate the second one. So Ms. Cox, did you want to go?
Barbara Cox again from HealthPartners. Thanks for the question. HealthPartners is unique in that we do negotiate directly with the drug companies. The only thing that we use a PBM for is claims processing. This is similar to what the state does. The State Department of Human Services uses a PBM for claims processing, but they, I understand, negotiate, and we negotiate directly with those companies. And we'd love to have our pharmacy director, Young Freed, come and present on her work. She does a great job.
Lynn Nelson from Blue Cross, and we negotiate similarly to how Mr. McLaren described with Medica. But I wanted to answer the other question when you said why just insulin, because it was the right thing to do for right now. But we always have to be cognizant of the upward pressure on premiums. So though we would like to look at everything, we can't let the manufacturers off the hook for the price. And so we are continuously trying to negotiate the price, but we can't always do that. We can't do it ourselves. We have to rely on some work with the federal government. And we very much supported Dr. Morrison's bill last year on drug price transparency. So we're trying a variety of options. There's not one single bullet.
Ms. Worcester.
Ghita Worcester from UCare. As a 430,000 member plan, it would be very difficult for us to negotiate if our competitors are struggling in some ways with Blue Cross, BlueShield, and Medica as an example. But we did seriously look at other drugs, and in the individual and family plans, many of you may be aware that there are metal levels in how the federal government put together the way we can offer benefits. And when we modified the insulin coverage, we started to hit at the top of one of the levels already. So we're going to have to go back and figure out how to do this in a way that will be allowed in the model that the federal government has for the metal levels to do any kind of modifications further in drug coverage. But we very much acknowledge that this is just the beginning of a long journey in controlling the costs.
Mr. McLaren, or Representative Schultz, go ahead.
Well, thank you. So it sounds like, what we have right now, the market's not working. You're not able to negotiate lower drug prices. So it sounds like the government may need to step in and correct this this problem. And I guess what other countries are doing is they're regulating drug prices. And maybe that option is something that we need to seriously look at, is making sure that we can regulate prices so they're not price gouging, so they're not making a profit off sick people. Thank you for that input.
And Ms. Cox?
I just want to answer the second question from
please.
Representative Schultz. Our coverage for insulin with a $5.25 is actually the same for all our outpatient pharmacy, save for the specialty pharmacy.
Okay, and did everybody answer that question? I'm not sure if we, did you? Okay, Mr. McLaren, did you answer that as well?
I didn't, but I'd be happy to.
Okay, why don't you go ahead?
So again, for the record, Jay McLaren with Medica. The answer is similar to what Ms. Worcester said. Basically, particularly in the individual market, you can't give a $25 copay to everything if you want to offer a bronze plan. So there's just realities of different things. And also I'd agree with what Ms. Nelson said from Blue Cross. This is something that we had the ability to impact now for 2020. And we took advantage of that and are quite frankly very pleased that we did something on this topic.
Okay, thank you. Representative Grunhagen.
Oh, thank you, Madam Chair. Just a quick question. Do you know of legislation that's been passed by other 50 states or 49 states and or is pending at the federal level that might help with the cost of drugs going up exponentially without hurting research and development on drugs? Are you aware of any states that have done something that's actually worked pretty well?
And who would like to answer that, if anybody?
So, Madam Chair and members, this is
Mr.
Jay McLaren with
McLaren.
Medica. I think to answer your complete question, Representative Grunhagen, I'd want to defer to the pharmaceutical manufacturers because your full question wasn't just about what can be done about price, but it was what can you do about price without impacting R&D and other things.
Yeah.
So I think they'd be better suited to answer that question.
Okay, anybody else want to weigh in? No, doesn't look like it. Okay.
Lynn Nelson from Blue Cross.
Okay.
I just want to mention that there's a similar bill to Dr. Morrison's bill that was passed in Oregon and California for drug price transparency.
Madam Chair, just has it
Representative
helped?
Grunhagen.
Madam Chair, Representative Grunhagen, it is in the very early stages right now. So I would have to look at that.
Yeah, okay, all right, thank you very much. Well, I appreciate that you're all here and that you came in to talk about this. I guess I have a question for you. If I'm not seeing anybody else on the list right now. So we haven't talked as much about the cost of insulin supplies. And I don't know if that is in the same bucket with the insulin itself under the coverage that you offer. But, you know, obviously if a diabetic can't test their blood sugar, it's not as meaningful to have insulin. So how is this handled? Is there also a copay cap on that? Or is there anything that I don't know if you came prepared with that information, but can we try and give it a shot, Mr. McLaren?
So, Madam Chair, members, Jay McLaren with Medica. The $25 cap in co-payments for our fully insured products applies to insulin. To your point, it does not apply to the supplies. So again, it's a different type of expense where it's not ongoing, but the normal cost sharing would apply to those supplies.
Okay.
Madam Chair,
Nelson.
Lynn Nelson from Blue Cross, and the zero cost sharing only applies to insulin at Blue Cross, but I just want to mention that also the zero cost sharing, they do not need to meet their deductible before that kicks in. It also would not apply to their deductible because it is $0.
Right. We can apply it if it's zero, right?
Zero.
Sure. Okay, Ms. Cox.
Barbara Cox from HealthPartners, and thanks for the clarification, Ms. Nelson. The same coverage applies to our deductibles, that this $25 or $5 copay applies before the deductible is met. And I'm sorry, I don't know the answer to your question about the supplies, so I'll follow up with the committee.
Okay, that's great. Ms. Worcester.
Okay, Madam Chair, members of the committee, ditto on the clarification about the copay not applying to the deductible, but then it goes toward the maximum out of pocket, so that can mount up. I did expect that you might ask something about the supplies, and while a glucometer isn't very expensive, the test strips can come between $50 and $150 a month or more, depending on what a person needs, and that is a large amount. When the IRS did the explanation for the HSA compatible plans, they did not include the supplies in the regulations, so that's something we still need to work on.
All right, thank you for that. So, you know, one thing that occurred to me when all of you, we started to hear about various of you reducing your out-of-pockets for insulin was, there's always an issue about adverse selection when we're talking about people choosing plans. And I don't know if any of you would want to address that. I mean, I know maybe we do some risk adjustment. I don't know how much of that we really do now. But, if you're advertising yourself as the plan where diabetics can get the lowest cost, possibly you're attracting more diabetics. And diabetics have high costs. They're people with pre-existing conditions. So I've kind of wondered whether that, and what you're all doing is kind of counter to that expectation. You are making it easier for diabetics to get what they need within your plan. So I just wonder if there was Any thinking about that, if you would care to say, maybe you don't want to say, when you made those, when your companies made those decisions?
So,
Mr. McLaren?
Madam Chair and members, yes. So some of those things did come up in conversations just from a policy perspective, and to address what you talked about, there is a federal risk adjustment program for the individual and small group markets in Minnesota that does help to try to mitigate the effect of adverse selection for a number of different conditions, diabetes being one of them. But just for the members' knowledge, it does not fully make up for the cost of a diabetic on that plan. So that's what I will say about that, Madam Chair.
Okay, Ms. Nelson?
Madam Chair, I just want to respond. When we were looking at this, we did take a lot of factors into consideration, but one was the prevalence of diabetes in those that use insulin in our current membership, and we put that before thinking about whether we would be adversely selected or not. Because we do have a relatively high prevalence in the fully insured market right now, we thought it was vital that we address the members we have now instead of thinking the members we may have in the future.
Great, that's great. And of course, we can't fail to mention that if diabetics get proper care, their costs are lower, right? We've heard so many stories. If people don't get their insulin, they end up in the emergency room, they end up in the ICU. That is very expensive. So I assume that when you're an insurer, it's in your best interest to keep your members as healthy as you can by providing that kind of essential care, and that's a good kind of cost control measure. And I see some heads nodding. Ms. Worcester?
Madam Chair, members of the committee, it was a nice segue to what I wanted to say. When we looked at this, we looked at the risk adjustment and our members, but also we did identify that assuring the people were getting access to their insulin in a timely manner, coordinating with their physician office, was actually something that was going to improve outcomes and potentially reduce costs, not increase costs for us.
Mr. McLaren?
And I'm sorry, Madam Chair, thank you. That was something I was thinking of as well, is that
Yeah.
they were giving their responses. In our deliberations inside Medica, we did talk about looking next year as we roll this out, adherence to insulin and how that impacts, ER utilization by diabetics and the like, so that we can track and see what that experience looks like next year and beyond. And we'd be happy whenever we have some of that data to come in and present that to the committee.
That's great. Ms. Cox? I gave you all a really great softball, didn't I? Don't say I never did anything for you.
Well, again, we didn't have any recent discussions about this because we did have this $25 copay option previously, but on behalf of the 2,000 doctors that work in our system, I think our integrated system takes the medical part of the care really seriously, and just because I was at this testimony last night for our medication therapy management presentation, diabetes was one of the measures that they showed and how it lowered cost, and HealthPartners covers MTM. So that's another way that we make this work.
Okay, and so let's see, we have Representative Bierman.
Thank you, Madam Chair. So I just wanted to go back just a little bit when you were volunteering perhaps to get us some more information on the components for diabetics. I recently was door knocking a house where as I spoke to the members, it turned out there were 4 diabetics in the house, and they told me at length of the fact that their components, the tubes that they had to replace and the test strips and the pumps, which are recurring costs over time for all of them, that they could only that could only be sourced from one place. And I'm just wondering about the competition in the market for those products, and if you're willing to give us some more information on those other aspects, if you could include that, I would really appreciate it.
Okay, so you're not looking for an answer right now then, Representative Bierman. Okay, thank you. All right, well, I'm not seeing any other questions here. I just would like to make one kind of final comment on this topic. I mean, first of all, I think all of us are very happy to see this happening because I think I remember seeing some person, I don't know if it was here, maybe in committee or somewhere, just saying that they just, when they heard that some of the companies were going to cap the out-of-pocket, they just cried because it made such a difference in their life, So, I mean, yeah, Representative Halverson, I don't know if it was maybe you said that, or I don't know who said that, but, you know, it was very striking to me that that was the case. So, I mean, these things are really very meaningful to Minnesotans. I just wanted to kind of respond. Representative Schultz was mentioning, you know, how we could address the problem. I think there is actually a pretty, at least a solution very much worth trying that is right here in front of us in Minnesota, and that was the governor's proposed pharmaceutical buying pool. We could use the power, you know, you have talked, answered Representative Schultz's question, some of you by saying that you don't have enough buying power to drive down prices. But as a state, it's hard for me to believe that we don't. And I'd really like to see us aggregate our buying power. I don't think that I think that the companies would have a much harder time suing us for doing that than for trying to regulate their prices directly. And I mean, we've got some other solutions out there. Representative Morrison's transparency bill, which is, we're going to be hearing more about that, and other solutions as well. But I continue to believe that using our buying power as a state to get better prices is something that we really can do. And starting in our public programs, but ultimately for everybody in the state, 5.5 or so million of us, that's a lot of people. And it's a big market. And we could be saying, you know, this is, you want to sell to us, we're going to negotiate the price with you. And then we could all benefit from it, whether through our health plans or through government programs or however we would do it. So I just wanted to put that back out there. Representative Halverson.
Thank you, Madam Chair. And I wasn't actually waving at you saying, yes, it was me who cried, although you could probably assume it was me. I spent a lot of time in this room, but you know, in acknowledgement, everybody who's on this committee, we have to face really harsh realities that a lot of other committees don't have the kind of stories that we have to listen to. And so thanks to everybody who shows up and is part of these conversations and serves on this committee. Because I think everyone who signs up for HHS signs up because they have a passion for this, for the people of Minnesota and the health of people in Minnesota. So I wanted to say that. But what I actually had raised my hand for was to just notice that we have had conversations over the years about how Minnesota is served by health plans in the state and the potential for being served by health plans outside of the state. And the plans that are sitting at this table are all based in Minnesota and are all nonprofit. And we had a lot of conversations about what's good with regard to delivering healthcare in Minnesota, and should we add or for-profit health plans? And I think it's notable that these are Minnesota-based companies responding to the voices of Minnesotans, and that they are nonprofit health plans that's stepped up. I wanted to make note of that.
All right, thank you. So just members, before we adjourn, I just want to note that we are going to be, as part of the mini session, we're going to be having more discussion in Rochester about the price of pharmaceuticals. So if anybody is, you know, signed up for that one, it'd be great to see you down there for that. That's October 2nd, right? Yep. And the hearing will be at 2 p.m. So with that, thank you very much for coming today, members, to hear this really important topic. We are adjourned.